Good evening friends, this is Dr. Oak and welcome to my channel Critical Care Basics. And in this lecture series now we are starting on how to treat a patient of stroke in ICU. So in a series of lectures, maybe say 4 or 5, we will cover the basic pathophysiology, clinical features, investigations and management of stroke. So let's begin. What is a stroke? A stroke can occur when blood flow to the brain is abruptly either blocked or there is a sudden bleeding inside the brain. And as we all know, stroke is a medical emergency because stroke can cause lasting brain damage, long-term disability and even death. Basically, there are two types of stroke. In the first type, there is a block in the blood supply of the brain, a particular area of the brain, maybe due to a atheroma or a clot or thrombus forming, or maybe a clot coming from somewhere else, which is called an embolus. And there is resultant ischemia and necrosis of particular area, infarction of particular area of brain. And the other stroke is the rupture of a blood vessel causing hemorrhage in the brain. Why the need for a protocolized treatment of stroke? Because first of all, stroke is a leading cause of morbidity and mortality. Third leading cause of mortality. 1.8 million cases of new stroke every year. Around 5,000 strokes occur per day in India. And about 6 lakh deaths per year. And 63 lakh DALYs, means disability adjusted life years. So it causes a lot of burden on the healthcare and society in general. Stroke and its consequences in India are of epidemic nature. However, the treatment application is endemically low. So the actual treatment of stroke, which should be done as per the latest guidelines, is very low in India. So over 1.5 million stroke cases occur every year. 70% of them are ischemic strokes. Fourth leading cause of death. 7.3% of all patients of stroke die. Fifth leading cause of disability. 3.5% of DALY. And what is most disturbing is there is dismal thrombolysis rate. Only 0.5% of all stroke patients are receive thrombolysis. So that is a very poor state of affairs in India. The most common stroke is the ischemic stroke. So 87% of all strokes are ischemic. Only 13% are hemorrhagic. In ischemic, 20% are atherothrombotic strokes. So a clot forms inside atheroma which ruptures, blocking the artery in the brain. 25% are small lacunose strokes which could have varied etiology. 20% are embolic stroke with predominantly emboli coming from the heart or sometimes elsewhere. 30% are cryptogenic, that means young patients who have stroke but the cause is not known. And 5% are other like SLE or other diseases, autoimmune diseases and so on. So we will talk predominantly about ischemic stroke because ischemic stroke is very common. An ischemic stroke is a result of vascular occlusion in the blood supply. It could be due to thrombosis and embolic. Let's delve into pathophysiology of these two. First is the atherothrombotic stroke. In this, there is typically stuttering progression with periods of improvement. Stuttering progression means suppose you develop sudden weakness of right arm and right lower limb, and after some time it actually improves for a certain period of time and again it worsens. So that is called a stuttering progression. It could be a lacunose stroke in which small arteries are involved which go to the deep white matter, or it could be a large artery ischemia. This is of important concern because large artery ischemia are those strokes which can be dealt with mechanical thrombectomy, the latest and the most promising treatment of stroke nowadays. Risk factor for thrombosis apply here also: age, smoking, diabetes, hypertension, diabetes, and males are more affected than females, and there could be history of a transient ischemic attack. In these patients, if they have atheroma or atherosclerotic disease of the carotid, they may have a bruit. So let's talk about large vessel occlusion, because these are the patients who are who are the receivers of mechanical thrombectomy. So where are the large vessel atheromatic strokes? Where are the common sites of atherothrombotic blockage? First is the bifurcation of common carotid artery, then this siphon portion of the internal carotid artery, then the MCS stem. So this is an internal carotid artery. This divides into the middle cerebral and the anterocerebral. So this is M1 segment, M2 segment, M3 segment. So this is the stem of the middle cerebral artery. And then there could be intracranial vertebral arteries proximal to the middle basilar artery. So this is the vertebral artery, this is posterior circulation. So it could be somewhere in the vertebral artery before the formation of the basilar, or it could be at the origin of the vertebral artery. So these are the common sites of large vessel atherothrombotic strokes. Less common sites are origin of common carotid artery, posterior cerebral artery system, origin of major branches of the basilar artery, origin of the branches of the anterior and middle cerebral. Now, special mention about the lacunar strokes. So these are also ischemic strokes, but that is due to the involvement of the small arteries, small branches which go deep into the white matter. So lacunar infarcts are small, about 2 to 15 millimeter in diameter, non-cortical. So the cortex is not involved, the white matter is involved. Infarcts caused by occlusion of a single penetrating branch of a large cerebral artery. So suppose this is a middle cerebral artery, the small branch, penetrating branch gets blocked. So most common causes hypertensive microangiopathy, or there could be a branch atheromatous disease. So there is a atheromatous plaque at the branch which blocks the small artery, or there could be embolism, small embolism going to the artery, or endothelial dysfunction, or sometimes disruption of blood-brain barrier. So these are the various mechanisms or the hypothesis of causation of these lacunar strokes. So in imaging, in MRI, it looks like a small black dot in T2 weighted images. In diffusion images, it will be seen as a small white spot, typically only 2 to 15 millimeter in diameter. So as we'll come to see in next class about the clinical features, the clinical features of lacunar stroke are different in that the cortical signs are typically absent. We'll come to it later. The second most common category is the embolic stroke. So in embolic stroke, the total deficit occurs suddenly and at that instant. There is no stuttering course. So sudden onset with deficit maximal at the onset. Clinical findings may improve quickly. Same atherosclerotic risk factors will apply, but there could be history of a structural heart disease such as valvular heart disease or AF and so on. Can be precipitated by any activity, getting up at night to urinate, or coughing or sneezing. So the small embolus forms in the heart. For example, patient is a patient of atrial fibrillation, and in the left atrium there is a clot which gets dislodged and lodges into the artery in the brain. So these are the various reasons for embolic stroke. For example, cardiac stroke in which the anticoagulation is given, like LA-LV thrombus or atrial flutter fibrillation, recent MI, rheumatic heart disease with MS or AR, mechanical valves, or dilated cardiomyopathy. These are the patients who suffer from embolus clot developing into the heart and can get dislodged. In these patients, anticoagulation is given. There are other cases like patients with bacterial endocarditis and left atrial myxoma. Here again, there is a likelihood of thrombus formation inside the heart, but here anticoagulation is contraindicated. Then there are patients in which there could be possible cardiac cause like patent foramen ovale or atrial septal aneurysm or LV aneurysm with a thrombus. Then there could be disease in the ascending aorta and a thrombus formation there which could embolize into the brain. Sometimes in embolic stroke the cause is not known. And lastly, other rare diseases like dissection, moya or primary thrombosis. After the ischemic stroke, let's talk a little about the intracerebral hemorrhagic stroke. So this is only 13 to 15% of cases. Here there is gradual onset and progression during minutes to hours. So here the patient suddenly loses consciousness. So if the patient loses consciousness within minutes to hours, or the patient is disoriented, it is more likely that this cerebrovascular episode is a hemorrhage rather than infarct. Risk factors are hypertension, trauma, bleeding diastasis, illicit drugs like amphetamine and cocaine, arteriovenous malformations, and some racial factors. Blacks are more prone for intracerebral hemorrhage. May be precipitated by any type of activity, sex, other physical activity, and patients typically have reduced alertness. So a patient usually of ischemic stroke does not have reduced alertness. If the patient has reduced alertness or there is sudden unconsciousness, it is more likely to be a hemorrhage. Another type of hemorrhage is subarachnoid hemorrhage. Most of the vessels of the brain are on the surface of brain between the pia and the arachnoid. These vessels look like this, and when this subarachnoid vessel ruptures, then the blood goes to the various fissures and see it looks like white halos in the CT scan, white diffuse type of picture shadows on the CT scan. So they can present as abrupt onsets of sudden severe headache, right? Focal brain dysfunction, less common than with other type. And you must have heard about Bruce Lee. Bruce Lee suddenly had severe headache. So he probably suffered from a brain aneurysm which ruptured and caused sudden subarachnoid hemorrhage. The risk factors include smoking, alcohol abuse, genetic susceptibility, like patient with polycystic kidney disease or some patient of family history have more likelihood of forming aneurysms in the brain, in the arteries of the brain, which can rupture. There could be drug history, like patients who are taking cocaine. This again may be precipitated by any activity including sex, and the patient suddenly, after having some physical activity, suddenly has severe headache and develops subarachnoid hemorrhage. Now let's talk again about the ischemic stroke. Whenever there is a block in the blood vessel, all of the tissue doesn't die suddenly. Normally the gray matter requires a larger blood supply, about 60 ml per 100 gram per minute, while the white matter requires about 25 ml per 100 gram per minute. Whenever there is a block in the artery, for example, if this region is supplied by, say, middle cerebral artery, and the middle cerebral artery gets, M1 segment gets blocked, so there is an initial core area which gets the blood supply of less than 10 ml per 100 gram. So this area actually dies. So this is called as core. Surrounded by that area is what is called as penumbra. This area gets blood supply from the leptomeningeal circulation, from the external carotid, and from other collateral branches from anterior and posterior cerebral arteries. So what happens is this area is able to maintain a blood supply of, say, 20 to 25 ml per 100 gram, and this is the area that we have to salvage. So if this is not the blood supply is not restored within, say, about 3 hours or maximum 4.5 or 6 hours, then this area will also die and get incorporated in a core, causing a larger infarct and a larger deficit, right? So the area of ischemic territory which can be saved is called the penumbra. The ischemic area with no or little collateral blood supply will die, which is called, and have irreversible damage. So this is the core. So this tissue is dead. What we are planning or focusing at is saving this area. So all the treatment of the ischemic stroke focuses on saving the penumbra as much as possible. Initially, whenever there is a ischemia, brain tries to adjust the blood supply. That is called autoregulation. So as you can see from this, cerebral blood flow between the blood pressures of 50 to 150 is kept constant by adjusting the caliber of vessels. So if the BP is low, there will be cerebral vasodilation. If BP gets high, there will be vasoconstriction. Similarly, if there is a blockage of blood vessel, initially the cerebral blood flow will be augmented by local vasodilation. Also, there could be genetic changes in the penumbra, so that will improve the oxygen extraction. So body tries to conserve the penumbra and save the patient from a larger infarct. So the idea behind showing this slide, if the patient has a hypertension during stroke, do not drastically reduce the BP, because the cerebral blood flow is mean arterial pressure minus intracerebral pressure. So whenever there is stroke, the intracerebral pressure increases. So if you reduce the blood pressure, the patient's cerebral blood flow will be compromised. Now, how do we treat a stroke? So what happens is, what the goals of treatment are, there should be rapid recognition of stroke. So you should diagnose stroke as soon as possible and timely commencement of the treatment. So if the patient, you should try to open up the artery. If it is ischemic stroke, you should try to open the artery by drug or by mechanical thrombectomy as soon as possible, provided there is no contraindication and patient is a candidate for reperfusion therapy. And then early key management of the stroke in ICU, including proper oxygenation, blood pressure management, body temperature management, blood glucose level, and the rest of the supportive treatment. Lastly, the prompt shifting the patient to the intensive care after the acute care of stroke has been done. So this is stroke chain of survival. Just like in ACLS, there is cardiac chain of survival. Similarly, in stroke, first is recognize symptoms and activate EMS. In India, there is no properly formed EMS, so you just have to call the ambulance. But if you have a structured EMS, it should be immediately activated. Timely EMS should respond, and it should transport the patient to a center which is specialized in stroke treatment, or whichever is near, so that at least if that center does not have a facility for mechanical thrombectomy, at least the center should be able to give proper timely intravenous thrombolysis, provided the patient is a candidate, and then guideline based treatment and quality post stroke care. These are the 8 Ds of stroke. First is detection, rapid recognition of stroke symptoms, then dispatch, early activation and dispatch of EMS, delivery, rapid EMS identification and management and transport, door, appropriate triage. Triage means whenever the patient arrives at the emergency department, you have to assess whether the patient is very critical, requires urgent attention, or the patient is semi-critical or less critical. So every stroke patient comes in the red flag triage, so immediately he has to be attended to. Then data, rapid triage, evaluation and management in emergency department. Then decision, stroke expertise and therapy selection. So you have to select whether the patient is a right candidate for any treatment like stroke thrombolysis, intravenous thrombolysis or mechanical thrombectomy, and accordingly. If the patient is a candidate, then fibrinolytic therapy or endovascular therapy, whatever is available. And lastly, disposition, rapid admission to the stroke unit after the acute treatment is over. So as soon as the EMS arrives, there should be effective pre-hospital management. This is crucial. If there is cardiac arrest, you manage CAB, compression, airway, breathing. SOS, give oxygen. Perform pre-hospital stroke assessment like Cincinnati scale or FAST scale, we'll come to it, and establish and record the exact time, because if you know at what time the patient actually had the stroke, what was the last time the patient was normal, from that time you have to calculate the time that you can afford to give thrombolysis, for example first 3 hours or 4.5 hours. So in advanced centers there is a stroke ambulance which has a stroke unit including a CT scan and a neurologist. So by the time patient reaches the hospital, CT has been already done, and if the patient is a candidate for thrombolysis, already thrombolysis has been done. So such type of stroke units are available in developed countries. We in India are lacking, but this is where we should be headed. So as soon as this has to be taught to all the patients, all the general people also, so that they can immediately recognize what is stroke. So what does this FAST say? Phase. So look face whether there is uneven, if there is a deviation of angle of mouth. Secondly, ask the patient to lift both arms. If one arm is falling down, ask the person to raise both arms. If there is a drift, he cannot raise the arm or the arm falls down, then probably the patient has a stroke. And speech, whether the patient is able to talk clearly. So ask the person to repeat a simple phrase. Is their speech slurred or strange? So if face, arm, speech is abnormal, then time is important. So note the time and immediately transfer the patient to a stroke center. What happened with this fast examination was many posterior circulation stroke got missed. So this was later modified into B fast, in which the balance and I was added. Like if there is a loss of balance or gait disturbance, it could be a posterior circulation stroke. Or if there is a blurred vision, it could be again a posterior circulation stroke. So instead of fast, now it is B fast. In case we feel that the patient has a stroke, emergency, you get a call and our emergency team rushes to the house of the patient, and if the fast is positive, then the patient should be rapidly transported to the closest facility capable of treating stroke. So suppose you have a patient, you have a hospital which is nearer and has an ability to manage stroke patients, then you shift the patient to the nearest center, because time is brain. Bring witness or a family member or a caregiver. So if the patient who has seen it happening can exactly tell the history and the time. Alert receiving emergency department. So you already talked to the emergency department of the hospital where you are shifting the patient or taking the patient. Important, hypoglycemia is a big mimic of stroke. So if you check the sugar and maybe sugar is 40, the patient may not have stroke, it could be just hypoglycemia. So always check the blood glucose. This has happened many times in our hospital when the suspected stroke patient, and we immediately rushed to the patient and patient was found to be hypoglycemic. So check and record the blood pressure, right? And establish cardiac monitoring and IV access if possible. As we have just discussed, the patients do better when they are shifted to a proper stroke unit. Patients who receive organized inpatient care in a stroke units are more likely to be alive, independent and living at home after 1 year. So pre-hospital care networks have been developed that facilitate patient transfer directly to the hospital with the stroke unit so that the delays in starting treatment is minimized. So a systematic review clearly showed that a patient who gets admitted in a stroke unit does better. Thank you for watching. In our next class, we will consider what happens after the patient reaches the emergency department. Thanks a lot. If you're liking these videos, please like, subscribe and share. Bye-bye.